What's up, gentlemen? This is Rising Phoenix Podcast, the podcast about how to rise up after your divorce. I'm your host, Michael Rhodes. Let's get into it. Hello, and welcome to the show. This is episode 80. Before we begin, I want to take a moment to dedicate this episode to Mr. John Taylor. John was a member of our Divorce Support for Men group on Facebook. And recently, John took his own life. I knew John. I spoke to him on the phone several times and messaged with him quite a bit. So his death was definitely a shock to me. But I didn't know John that well. I didn't know him outside of the sphere of divorce support. So before deciding to dedicate the episode to John, I reached out to his daughter, his oldest daughter, and spoke with her and her sister and got to learn a little bit more about John. And what I learned, some of the things that I already knew was he was a veteran of the United States Air Force. He served our country for 21 years. He was a father of 6. And what I learned about John was, as described by his daughters, was a man with a big heart. He loved the Eagles. He was from Philly. He loved golf, and he was a car guy. He was an animal person, though wouldn't admit to it, as described by his oldest daughter. He was more than anything. He was a man that worked hard for his family. He cared about others. He put others before himself, and he would do whatever he needed to do to make sure that his family had before he had, always. John was loved, and John will be missed. So this episode is for him and is in his memory. This episode is going to focus on suicide. I reached out to Dr. Tyler Black, found him on Twitter. He is a suicidologist. He is an expert in suicide. So that is the majority of the topic that is covered. And before I formally introduce this episode, I also want to say to you out there, if you are in crisis, if you are having these thoughts, if you are lacking hope, please reach out to someone, to anyone, and talk. There is hope after divorce. I promise you, there is. So please just reach out and ask for the help that is out there. Here we go. Episode 80. Joining me today is Dr. Tyler Black. Tyler, let's just jump right into it. And why don't you tell us a little bit about yourself?
Sure. So I'm a psychiatrist at the University of British Columbia. I specifically work more with kids. So I'm a child and adolescent psychiatrist, but really one of the reasons that we've connected and one of the things that I do a lot is research in suicide and suicidology. People probably aren't aware of suicidology. It's not a much talked about specialty, but of course, suicide is a leading cause of death, and especially in younger people, especially in men. And so basically suicidology is the study of suicide. And I've taught about suicide risk assessment, and my primary work is in emergency psychiatry. So I typically see people in crisis.
So sidebar, and this happens all the time, rabbit holes as I call them. How did you get started into that topic?
Yeah, I mean, this is going to sound. So first, I'll preface this. So people are watching. I know that there is. We've talked a little bit about that. There's been a recent event in your group, and people have varying contacts and thoughts and memories of suicide or suicidal thinking. I always say for something like this, I'm going to talk very frankly about suicide, but
please do.
The best time to listen to it, the best time to be a part of that is when you're in a good space to do so. Like it's not generally a great idea to be thinking a lot about suicide when you're down in the dumps. So I usually say, wait for yourself to feel a little bit strong, and I'm not going to censor myself to be very to be overly sensitive, but I would say a lot of people tap out on these conversations, and that's okay. And then just return to it when you feel a little bit better. For myself, I my first day of work as a psychiatry resident, I arrived to a hospital and there was a man hanging from a tree, and I had never done a lick of psychiatry outside of my core medical student work and a couple of electives. So it was quite a thing to see. And then the response to it within the organization was really varied. I got lots of different teaching. I had people teaching me opposite things, like so and so was more at risk, so and so was less at risk. And so I just did what I generally do. I went into the research and I realized that a lot of the things that are taught about suicide aren't true, and they haven't been true for a really long time. And so the culture of suicide is still mired in a lot of stigma. Even in research, there are some medical truisms that have never been true and are continue to be taught. So it's one of those things where I thought, well, I can become an expert in this. It's really interesting to me. And like anything else, people think, maybe it's a morbid topic, but medicine in general is about death and dying. If you're an oncologist, trust me, it's pretty morbid if you're dealing with cancer all the time. So really, I just want to try and be helpful.
So let's dive into the meat, the heart of the matter, as it were, and discuss the statistics. Do you have? I think I have some, but I'm not the expert, so I'm going to rely on you. What are the stats maybe in the U.S. or the world, but for men in particular? How many men? With the latest set of data are killing themselves in whatever metric you have, daily, weekly, monthly?
So it's really, we typically think about suicide. There's a term that is often used called rates. So a rate is per population, and typically in death, we talk about mortality rates as being per 100,000 people. So when a figure is expressed, it's usually per 100,000 people per year. So for example, in the United States, for men, it's about 22 per 100,000 per year. And so if you take the entire population of the United States, which is, I think about 150 million men, or maybe 175 million men or so, you get to quite a high number of raw suicides. But of course, suicide has a number of variables that affect it. So there's a peak in midlife. For men, there's a peak in later life, especially in the United States, much more so than other nations. And typically, in the Western world, we see about a 3-to-1 ratio for men to women dying of suicide. Especially later adulthood, that ratio gets really distorted. It can be up to 13-fold at age 75. And women seem to have a bit of a decreasing rate of suicide after age 55, and men have an increasing rate of suicide after age 55. So there's a bit of a gap there. But it's important to also remember that that's not like a genetic gap, because there are cultures like China, Bangladesh, where more likely women are dying by suicide. And so it's not just this is a Y chromosome thing, or this is some pan thing. It does seem to be more prevalent in Western society. So the ratio in Asian countries is about 2-to-1. The ratio in North American countries is about 3.5-to-1 or so. So there's a variance based off of where you live and what your culture is too.
I'm shocked that I'm not shocked that there are countries where the disparity is less. I am shocked that there are countries where females kill themselves at a higher rate.
Well, it's difficult. You'd think something as easy as what's the suicide rate in a nation is easy to know. But for example, Italy reports 3.7 per 100,000 deaths by suicide, and America reports 14. And I'm sure that all entirely has to do with the Catholicism of Italy rather than the rate of death by suicide in Italy. Stigma and cultural norms and the way that these things are investigated, and whether or not suicide is acceptable in the culture or something that a coroner can say, these all play in. And of course, the statistics coming out of Bangladesh and China, you can wonder a little bit about, if you had access to the same data, would you come to the same conclusions? But it's been relatively well held in China that it's at least 1-to-1. But some of the studies show that women die more of suicide, and then in Bangladesh as well. Yeah.
Do you think that in America and then in the rest of the world, so you sort of alluded to it, is suicide underreported?
Well, it's underreported and it's hard to call. So I'll give a couple of examples. If someone's found dead of a drug overdose, for example, and they clearly intentionally used the drug,
Right.
it's a drug of abuse like
Sure.
fentanyl or heroin or something, but the question is like, what was their intent when they took it? Suicide is the intentional act of death.
Mm,
Um, and a lot of people die of overdose without that. So you can imagine how hard of a call that is.
mm,
For coroners that investigate, they try and get to know pretty much all unnatural deaths in most Western societies are investigated by a coroner service. And they get to know the family and talk to people who know the person and try to figure out what's going on for them and try and construct whether or not the death was intentional or not.
mm,
And sometimes it's very hard to tell. So there's a group that we don't know.
mm.
I would certainly say there's a tendency. For a while, it was kind of reported that religiosity decreased suicide. But one of the big moderators for that is coroners who are religious are less likely to call a death a suicide than coroners who aren't religious,
Really?
because you're basically condemning that person to hell, say in a Catholic country or something like that.
Huh.
Um, so we think that the social connection of religiosity can be very helpful, but a lot of the country by country effects, you can directly plot it with the secularism of that country.
Huh.
Typically the more Roman Catholic the country, the lower the suicide rate.
Wow,
So
that's interesting. Yeah, I would have never have thought that. I'm assuming we probably don't have that trouble here in America in terms of,
well, it's county to county. We'd love to imagine that there's this like really robust way of doing things, but of course,
yeah,
every state, every county often leaves up to itself how to adjudicate these things, how to report them. The CDC expects death reports for all unnatural deaths with a certain amount of characteristics,
mm,
but a surprising number of things aren't in that data. So, for example, you know. We still to this date don't have is this person gay or not,
mm,
and so for all of the we know quite confidently that suicide attempts, suicide thinking, we're quite confident that suicide deaths are more common in people who identify as gay, but we don't have any national statistics on that because literally there's no box for is the person gay or not. um,
yeah,
and you can imagine that America is a very divided country. There's very different
yeah,
approaches to lots of things. Drug
true.
overdose deaths in a very conservative state might be more often called suicides,
Mm,
because of the pejorative way in which drug overdoses are viewed. So there's variability. You wouldn't want there to
yeah.
be lots of variability, but there is, because it's
Yeah,
up to the
well,
coroners. Yeah.
yeah. Well, that aside, I mean, it's still clear that at least in America, that men are killing themselves at a higher rate.
Yeah.
Why? Why is that? Why do
Yeah.
you think that is?
I mean, there's some tropes that are out there, and I challenge those a little bit. Like, I always feel like there is a traditional form of masculinity that involves never admitting that you can't handle something, being too,
Yeah,
any struggle is a sign of weakness. I
right.
do think that's an issue, but I think that's overcalled and it's a little bit simplistic because I have many male friends in my life and we can talk about really emotional stuff. We don't do it we don't do it in the same way that say women talk about
Right.
their emotions, but my friend could call me if he was having a hard time and we'd chat about it. And I've had my brother cry to me. I've had my friend cry to me, so I think there's this kind of stereotype that men don't open up about their emotions.
Yeah.
Um,
Yes. Yes. I believe that. I mean, I
yeah,
believe that.
I think there's some truth to it because there is that
Yeah.
kind of traditional, what in the research we call sort of hegemonic masculinity, which is basically weakness is what happened. Like it's a sign of weakness to need help.
Yeah.
That talking emotionally is a feminine trait.
Yes.
And there's a lot of sort of that sort of you can't be feminine.
Yeah.
Approach that some men have, but there's also some other things that we have to put on the table. Men are much more likely to be involved in problematic drug use. Men typically bury themselves in work and responsibility, and often men socially cast one of their identities is their role. So we see in a lot of Western societies traditionally the feminine role as being one of within the family, and that never retires. But when you're someone whose role is I'm the sales manager of whatever,
Right.
and then you lose your job, unemployment hits men harder than it hits women. We see unemployment as a much stronger risk factor in men than women for suicide. The same for divorce. Divorce hits men much harder than it hits women in terms of a risk factor, because again, men often see themselves as the ideal partner, and I'm so and so's husband, and so loss of role can be a really big blow to men, and men often put their roles functionally. If I'm not doing something, if I don't have something to show for it, it's not a role for me. So, the person who loses their job often finds themselves listless. The person who loses their relationship often finds themselves without an identity, and that can be a real tragedy.
Man, it just hits me so hard, but and leads to so many other types of questions. So, but then if, and I'm not saying you're wrong or disagreeing or agreeing or whatever, but if I think that's true, by the way, I mean 100% true in terms of losing identity. That's something that, in fact, my last podcast episode was just a solo one, and I was talking about identity.
Yeah, I heard it. Yeah.
Oh, thank you. I think thank you. I don't know.
Yes.
So, but if there's not reaching out, though, I mean, is that maybe I'm jumping ahead in terms of the solution, but if it's not that they're not reaching out, like if they're faced with a problem,
mm-hmm.
and part of the solution, at least I think it is that you reach out for help. Yeah. But you're saying that probably is occurring and probably isn't as much of a factor.
Well, I think it's a factor. It's just an overplayed factor. I think it plays into the stereotype of men rather than it plays into the reality of men. I think there's lots of men that would very happily speak. We know that men are a little bit more intimidated by professional help seeking. So talking to a therapist would be a lot different than, say, someone just on the street saying, "Hey, how's it going? You're looking like you're having a rough day." Right. So I think, there's this kind of stereotype of men as not wanting to talk about their feelings, but I think it's the mode of delivery. It's when is it available? It's reaching out early rather than reaching out late. A lot of men really hit, it's when the shit hits the fan that they reach out for help. And there's just that culture of not reaching out early because I can handle this or I got this. So I think some of those stereotypes have some truth and some of them are exaggerated. Yeah. So I certainly think it's a factor.
Yeah. So that I jumped around a bit, but that's why I created an outline. So when you say that men are a little bit more intimidated by professionals and a little less likely to reach out, and I see it in here. Sometimes they reach out in here. Mm-hmm. What the hell should we do when that happens? Because, and people are on my case about this, but we fucking failed. We had a guy in here and he's not here. And I get it. It's not my fault. It's not their fault, but the system that I have in place here, the ecosystem, it failed. Mm-hmm. It failed. It did. Now, I'm not saying it's my fault, but what are better ways then? Like whatever I'm doing, mm-hmm. It didn't catch this one. And maybe it is one and it's an anomaly, but I would rather not rest my head on that. I'd rather take action. So what are we to do as a peer and not a professional for a man that is on the brink, so to speak?
Yeah. Well, I'll start, and I don't mean this as a platitude, but I'm used to the feeling of people who survive suicide as feeling like they somehow failed or that they missed something.
Of course.
We use, unfortunately, in suicide prevention work, we use a lot of talk about warning signs and mental illness. And what that ends up doing is that makes, in all the people who survive a suicide, a sense that you missed the warning signs and you missed the mental illness. Yeah. And that's really unfortunate. It's one of the reasons why I'm not a fan of zero suicide campaigns or that every suicide is a mistake, because we don't actually get to see what's in the hearts and heads of every single person, and the ability. And there's many people who you couldn't tell that the next moment they're going to die by suicide. They don't have a diagnosable mental illness. That's only about 60% of people who die by suicide, 50 to 60%. And warning signs aren't as, while they do occur, they're so generic that you could miss them for anything. So if you look at some of the warning signs and you really think about it, it's like a change in personality. Well, my goodness, if someone gets a girlfriend, they have a change in personality. If someone, has a rough night, they have a change in personality. Like, so some of these warning signs, they can be helpful, but they also set up kind of what you expressed here, this sense of we were there, but we failed. I'd really like to make sure that you and your community and people listening to this recognize that you do what you can, but you can't be responsible for everyone's life or death. This is something that, as a physician, I've had to tackle very early, when patients who should have survived didn't, and patients who shouldn't have survived did. I don't get to control, as a physician, who lives or dies, and I have lots of knowledge and lots of expertise. So people who kind of go through this, they often are left with that sense of, what did we do wrong? And here's one of the kickers. It could be that you didn't do anything wrong. You did everything right. The outcome can still suck when you do everything right. So, that person having an outlet to go to, that person reaching out, all of the responses that received could have been exactly what that person needed. But the circumstances, or they got some other hit, or they got a phone call, or who knows what else happened. So I would like to formally relieve you.
Well, can I just say, I hate that fucking answer. I'm not saying you're wrong. I'm not saying you're wrong. You're the expert.
We all hate it. Yeah,
but it's just it makes me feel powerless. It makes me feel like, then, I don't know what's the what's the fucking point, is what I feel, because it I don't know, man. It's fucking frustrating.
You come to a place, and a lot of physicians go through this. A lot of people who work in suicide risk assessment go through this, and I certainly went through it, where you transition yourself from, my job is to prevent all suicides, to my job is to improve the lives of the people around me. Every person who comes in contact with me, I want them to leave contact with me in a better position than when they start out. I want to tip the scales in favor of them surviving. So if I identify a problem, I want to correct it. If I identify something that would help their life, I want to add it. But I don't actually get to see the final score. And man, that's frustrating. Yeah. There was I'll really drive it home in a very analytical way.
I love it.
There was a study where they had big Deep Blue, IBM's big supercomputer that beats all the chess masters, had a crack at 9 million electronic medical records from the state of California, trying to predict suicide. They had access to every bit of information that was ever written about that patient, going back far. The best the model could do was a positive predictive value of less than 1%. And this is Big Blue with 9 million EMRs. So with limited information, and the person sitting across from you, you're the idea of predicting and knowing whether or not someone's at risk is really infinitesimal. So I try to take this universal approach. Instead of being defeated by it, it gives me a mission. Every person I see, I can make their life a little bit better. There's something I can do to make something in their world better. And that becomes your motto when you're trying to prevent suicide.
Yeah, I'm not surprised by the answer, I guess, in some ways, but it's just, I don't know. It's so being analytical, right? You talk about analytical. That's my jam. Tell me, give me the numbers, give me the data. And now it seems like there isn't a way. And so, but with that said, though, are there things? But should I be looking for certain things? Is there certain, or is it just?
Well, I always think when you approach warning signs, don't do it from the I will catch everyone who's suicidal point of view. Do it from the really basic humanistic point of view. And I'll demonstrate it right now. Like, if I was talking to you right now and I felt like something was off, I would just pause and I'd say, hey, we've been talking for a while, but today seems a little bit different. Is something going on for you? Like, that is a real question with real care. Or I could just say, how you doing today? And whatever they say, okay, anyway, so I was calling you about what, like, we can treat people superficially, or we can treat people, with a genuine concern and interest for their life. And when you notice something when something's, seems off, some of the warning signs, quote unquote warning signs of suicides, are things like people seeming sadder than normal, or people giving away their possessions, or these, some range from the blindingly obvious, like telling them, hey, if I die, please take care of my cat, to the not so obvious change in personality. But if you notice something, I always say model the type of communication that we wish for. And we can all think of a time where we were struggling with something and we didn't bring it up. And it wasn't because we didn't want to talk about it, it's because there was a barrier. And so if you imagine, what were those barriers? Just attack those barriers. I just needed someone to reach out to me. So reach out to people. I just needed someone to not make it like a big deal. I didn't want to really make a big deal out of something. So don't make it a big deal. Hey, we all go through stuff. How are you doing today? I just wanted to check in on you. It's been a while since we chatted. These seem like really basic things, but they're super helpful.
So it's a matter of, staying in touch, right? Just trying to reach out and not wait for.
Yeah. Your group has gotten quite large, right? You said 6,500 people. So, you run the stats on, divorced men in a group, 6,500 of them. And, it's not surprising that there's a suicide in that group.
I always knew that. I always expect it. And that's why I always push so hard to prevent it in some way. And like, let's be conscious of it. Let's not post dumb shit about how can I get laid tomorrow? Like, let's not, you know what I'm saying? These are real verifiable facts. And that means therefore that it's more likely that this is going to happen. So let's try to do our best. So let's on that sort of note, what are some of the things that you, in a group like this or in any kind of setting, what are some things you should not do? Like, I don't even know if that's
well, I think you probably experience this. Men who go through divorce often get treated like they're going through a funeral. Divorces are, especially when you don't want the divorce, it happens to you, which I believe is kind of the group that you're about, is kind of this kind of unexpected divorces. But if you or I to give lay advice to someone, the best thing that can happen for you is when someone who doesn't love you leaves your life. Like, it's actually a really good thing. And so I think we can be a little bit overly negativistic about, if someone's in a black hole, you don't want to be like, and here's a few more things that suck about what you're going through. You don't want to be superficially glib, but I do think that you can take a tone that's very hopeful, because one of the, when we think about the keys to suicidal planning and thinking, it usually revolves around a stress that we can't manage and hopelessness that it won't get better. And so, there's nothing a lot of us can do about some of people's life stresses. We just have to man, that sucks. But the hopefulness, I'll always be here for you. You can spend time with me. If you can add hope to that person, you're going to amputate a lot of that suicidal drive, which we do feel sort of comes from that combination of an overwhelming stress plus the idea that it won't get better. So when we see men who are facing a criminal sentence and then they hang themselves in jail or something like that, they do that because they know they're going to jail. There's no hope for them whatsoever. And so if you could tell that person tomorrow, oh, there's a technicality, you won't go to jail, they're not hanging themselves. And so if you can add hope to someone, you can really amputate their suicidal drive. And so it's not about being glibly hopeful. It's about being realistically hopeful. This is a process. We'll get through it. You don't have to do this alone. I'll be here every time, you have a bad moment, just let me know, those types of things. And when you create a community like you've created, it would be hard, we'll never know. We don't get the numbers of everyone who touches your group, but it's hard to imagine that a group of people coming together and talking about such a life-altering thing could not be anything but suicide protective. So, I think there's lots that we can do. Yeah.
Why does it feel like, I feel like, I'm sure it's childhood shit and whatnot, but I feel like such a fucking disappointment because of this one guy. And I knew John not well, but I talked to him on the phone. We messaged, I knew his story, and I keep fucking coming back to
Yeah.
I was just thinking, well, did he get that? Maybe maybe I didn't do enough of that. Maybe he didn't get enough hope.
Yeah.
Maybe I was a dick one day, or you know what I mean? Like that fucking regret that won't leave me the fuck alone.
Well, grief and the way that we process loss also involves a little bit of denial of reality. Like you don't have the level of direct control over someone else that you wish you had.
That's the truth.
And that's that's why it's the whole group. But we don't have that level of direct control, and so I always come back to whatever you did for that person. Were you doing your best to make their world better? Were you doing their best to help them? And if the answer to that is yes, then that's what you're doing. You don't get to see the final score. I'll give you a really concrete example. I could give someone with non-Hodgkin's lymphoma the perfect chemotherapy and they could still die of non-Hodgkin's lymphoma. So it doesn't have to be that I made a mistake in treatment. It doesn't have to be that I had a bad approach or that I missed the early warning signs. It could be that things that are just not in my control, and I do the best I can to improve someone's quality of life.
Is that something as a doctor that you probably have to wrap your head around at some point, right?
You always sort of imagine, and TV does this quite a bit, that you do heroic measures and the person survives. And I have to say, I've seen a lot of heroic measures and I haven't seen a lot of people survive them. So the realities, for example, of CPR rescue rates are pretty low compared to what it looks like on TV. And so you do get used to this idea that we don't get to control that grand arbiter decision of what someone's health course looks like, but we have really good tools that improve the quality of life for people that we work with and give people a better shot. So if I give someone aspirin, who's at risk for a stroke, like a baby aspirin or something like that, I could be increasing the risk of other things, but I'm improving the risk of stroke. I don't get to turn off their ability to get a stroke. I just don't get that ability. So, it's just one of those medical factoids that you encounter that really drives home when you have patients who you really care about pass away.
What about people? I see it in here sometimes. People that reach out and almost all they say is like, I don't want to be here anymore. Like I found that typically, or not typically, every time someone does that, I don't want to say follow through because that sounds pretty fucked up, but you know what I'm saying? They don't. Right. Yeah. And so is that when people say things like that, is that again, it's probably hard to.
So there's a large scope. So in my world, child and adolescent, 16% of kids in any given year think seriously about dying by suicide, and 0.0048% die by suicide. So there's a huge, vast swath of people who seriously think about suicide who don't die. Yeah. And I think one of our leans that's often counterintuitive when someone says things like that is like, oh no, it's not that bad, it'll be okay, like almost quickly invalidating the experience. And I've always found that when someone's expressing that much suffering, the best move is to sit alongside them and talk about, yeah, that sounds awful. I totally get what you're saying. It must feel like there's just no way out of this. So, talk to them about what's going on, and then, gently push them towards hope. I think, like I said, you can really do it on a very almost like, I'm not listening to you. So someone says something like, oh, I just can't take it anymore. And you're like, oh, well, the weekend's coming, something. Right. You're right. You don't like, this person is saying, I don't think I can survive tonight. And you're saying, don't worry, the weekend's coming. But if you said, man, that must be such an awful feeling. You're telling me about this. Tell me why you called me today. Tell me what we'd like to talk about. What can we do? Let's get you going and let's get you doing something. I do find that men respond really well to activity. A brooding man can get real down on himself, but if once you start doing something, whether within your abilities, to ambulate, to get some movement going, to do something with your hands, to distract yourself, we're in a culture that makes media seem very negative. I can tell you through the one very traumatic breakup I've had in my life, 3 seasons of South Park probably saved my life. I just binge watched it until until I got through the initial shock of stuff. so, whatever it takes, but don't reject that feeling. It can be scary when someone says that, but we have a quick, we want to resist that tendency to say, no, you don't really think that.
Yeah.
You kind of brought up this idea that they don't sort of follow through, or this idea of attempts versus completions, or ideation versus completion. I take a very humble position of, I don't get to know what's in someone's heart and soul. So whatever they're saying, I'm just going to accept it at face value. And I'm going to say, okay, thank you for sharing that. What are we going to do from here?
Yeah.
If like in my risk assessments, I'll use the word attempt. That's defined, has a very specific, definition, but it doesn't mean they weren't serious about it.
Right.
Like you could do something that, is very low lethality, but you were in a real dire state when you did it. And so, and in the same way, some people, end up in the ICU and they're really regretful that it was a total mistake. So I've met many people in the ICU who, the moment I see them, they're like, oh my God, it was just a relationship. Why would I do that?
Yeah.
But I'm just glad they survived.
What about messages like, your children, in terms of like, they'll miss you. They'll, you can't leave them. Like, are those kinds of good messages? Because I see that a lot in here from guys giving that message. I don't know if it's good or not.
I think there's good aspects to it and there's bad aspects to it. So don't use it as a guilt weapon. Don't leave your kids is probably a little guilt inducing. However, one of the things that comes with suicidal thinking and depressive thinking generally is the idea that people would be better off without you. My kids would be happier if I wasn't around, or, life would be easier for them if I wasn't around. That is never true. I will tell you straight up, one of the downsides of my life and the career that I've taken is I have met so many families who've lost people due to suicide. And it doesn't matter how much conflict there was in the family. It doesn't matter how much dislike and hate and whatever there is going on in the family. When someone dies by suicide, everyone's harmed by that. And so countering that idea that people would be better off without you usually requires a direct conversation. I do this with kids all the time. I say, who tell me, my parents would be better off without me. I'm like, I've met a lot of parents who died by suicide, and not a single one of them has ever benefited from their child dying by suicide. It's always a devastating thing, even in some families that fight all the time. So I would say careful not to use it as a guilt weapon. Think about your kids, how much they'd miss you if you did that, and how disappointed they'd be in you. It's just adding pressure and guilt. But do recognize that this idea that they'd be better off without you is a complete distortion. That can't be true. We know that kids need their dads. We know that for a fact. So of course they'll be better with you. Of course we want you better. Of course we want you feeling better. But they'll be better with you than without you.
On that sort of same topic, can we categorically say that telling a man to stop being a bitch is not a helpful way?
Without question. This idea that crying, feeling weak, seeking help is somehow a feminine action is part of the reason why I still subscribe to some of that masculinity, that toxic masculinity talk, because it's definitely something you'll hear, especially online, where it's a little bit easier to be crass and crude. And I even see it sometimes as like I'm a tough love type of person, like, stop being a bitch and hit the gym or whatever. And like, I get it. You're an alpha male, but I promise you that just drives like a nail into that person. And it's totally counterintuitive. People respond really well to, here's what I did when I was struggling. So if you ever want to kind of try to introduce a different tactic than the one the person is doing, just do it from the here's what I did type of vantage point, rather than here's what you should do type of vantage point.
Right. Hey guys, I don't know how I feel like maybe I'm getting towards the end, but I could be totally wrong and find another rabbit hole. If you got any questions, throw them up. I don't know if anyone's going to have any, Tyler, but
no worries.
Are there any other countries like America in terms of the male disparity in suicide? You kind of talk Western, but like
pretty much all of the Western nations, everything from Australia to the UK to Canada, the ratio is between 3 and 4 men to women. And the there's a couple of like myths out there that adolescents are more at risk for suicide, when in fact you're actually most protected when you're an adolescent from suicide. It's midlife. We see a peak at around 40 to 50 for both men and women. And anytime you're talking in the large pool of statistics on suicide, it's really important to mention in any area that has Indigenous people, Indigenous males, especially young Indigenous males, that the rates are astronomical.
Like the rate of Indians, right? Yeah.
The rate of Inuit suicide in Canada for males, remember I was giving the number of 22 per 100,000, is 260 per 100,000. So more than 10 times the rate. And it's not because of any genetic factor. Again, it's just the systemic issues that and the impacts of colonization. Yeah, it's quite there's quite a risk added by being exposed to systemic things like Indigenous people face.
How much do you, being a psychiatrist, how much do you believe pharmacology should play a role in these things?
Well, if you have a diagnosis that pharmacology helps, pharmacology has a role. As a pure, we can stop suicide with a pill, probably not. Yeah. There is some signal that maybe lithium in the groundwater is related to the rate of suicide, and you'd have to have a huge randomized controlled trial that would somehow have to pass ethics, because again, we're talking at rates of per 100,000, so you'd need gigantic people in the study. But the evidence on that is pretty contradictory. Certainly, lithium seems to have a protective effect for people with mood disorders for suicide. But I'd say if you have a depression, treat your depression. And I am a psychiatrist, and I certainly think that pharmacology tools are useful. But that's not the only way to treat a depression. There are excellent psychotherapies for depression. There are somatic therapies. Some people choose to do neither, and they do things like ECT. It's a very stigmatized treatment modality, but a very effective treatment modality. And then, for mild to moderate depressions, we have tons of evidence that adding exercise, changing diet, there's lots of things that you can do for yourself that improve almost as well as most psychotherapies.
Really?
Depression, yeah. Once the depression starts getting to the moderate to severe category, you don't want to be relying on exercise or diet. You really do want evidence-based therapies. But I think in that space of mild depressions where you're functional but you're feeling down and low, there are lifestyle changes you could make that can really improve things. Yeah.
Well, how do you boy, that's a how do you know
yeah,
I would say self-assessment,
yeah,
right?
To me, there's two big questions of whether or not my depression is severe. Number one is, can I function? So there's three main areas in our life that we function. There's our occupation, there's our social world, and then there's our health. And if we're failing in any of those three categories, it's probably not a mild depression. If you can't get out of bed and go to work because you don't have motivation and you lose your job, you've got at least a moderate depression, right? And on the same hand, if you're someone who, like, you feel a malaise, things, you don't enjoy things as much, but you have your friends, you enjoy things occasionally, you're able to hold your job, you might have a mild to moderate depression, and lifestyle changes could be really helpful for you. But the best way to know is always to talk to your physician. Depression is a very treatable problem. Treatments work. If people who choose medication, first round, it's about 66% likely to be effective. By medication 2 or 3, you get that into the high 80s. Psychotherapy is exactly the same. Psychotherapies and medications perform evenly, and the combination of the two is superior to either by themselves. And so using a real evidence-based treatment for depression can really improve the outcomes of depression.
Well, I'm familiar with somatics. I did a little bit of somatic therapy myself.
Yeah.
I loved it. I recommend it to everybody. I don't know what ECT is. What is that?
Electroconvulsive therapy. So if you've ever seen movies and went over flew over the cuckoo's nest, the electricity to the brain, it's done very punitively in movies. It looks really inhumane. The reality of ECT is it's using an electric current to induce a seizure in the brain. For depression, extremely effective. Usually we use it when people can't for some reason do psychotherapy or medications, and so it's often used in people who for contraindications can't take medication but have a severe depression. There's a mode of brain stimulation called repetitive transcranial magnetic stimulation that's actually done in an office. You don't need anything, and the psychiatrist or the treating professional would be using a magnet to actually reverse polarities in your brain. And it's a somatic treatment that's showing good evidence. Probably not as strong as ECT, but good. And so there's lots of developing therapies. Yeah.
What are you? I mean, you're said primarily children, so you're probably just psychotherapy then, right?
We always prefer psychotherapy for kids. My neck of the woods is emergency tertiary psychiatry, so I kind of see the most crisis and worst of cases. So often there's times that I'm relying on pharmacology. And for some of the major mental illnesses like schizophrenia, bipolar disorder, psychotherapy alone usually doesn't cut it. There usually has to be some medication that goes with it. But in kids, we typically try psychotherapies first. Families are a huge part of how kids function. Schools are a huge part of how kids function. So we modify environmental factors as well.
Speaking of that, and again, rabbit hole. If you don't address some of these things, and maybe they're mild or whatever, just not an ideal childhood, whatever the hell that means. But don't you need to address those things? Maybe not good as a bad childhood. I don't know. If you don't address those things, right, ultimately, like, isn't that sort of the source and the heart of a lot of the, at least, as you get older?
You're describing sort of the impact of what we call adverse childhood experiences. What in the medical literature call those ACEs in later in life.
Yeah, I got like 6 of them or something. It's not good.
There are forms of therapy that are really keyed into understanding the why and going deep, and those if you imagine like a classical on the couch type of therapy, it's called psychodynamic therapy. It literally created by Freud and his colleagues, but it's much more advanced. It's not Freud's old ideas. It's a very advanced therapy. It's a long-term therapy with really the goal of understanding yourself better and where things come from. A lot of modern therapies for depression are very functional, like cognitive behavioral therapy is a little bit less about the why and about what to do. It's very manualized. A lot of people find some real benefit from working with a therapist to go back in their life. I think we'd be really remiss if we didn't talk about this. You brought up that you had a number of adverse child effects in your life. We know that men far underreport the amount of sexual and physical abuse that occurred in their life. We often play off physical abuse that happened early in our life as just growing up. I had a rough childhood, and that's the euphemism for I suffered physical or sexual abuse. It's like, we should be, physical abuse, emotional abuse, sexual abuse. These are things that are done to children by abusers that cause long-term psychological harm. And certainly exploring those with a professional, especially if the ramifications of it echo in your head. So, a lot of the cruel things said during physical abuse often replay in our head as adults, or kind of drive a narrative as an adult
all the fucking time. But I know the source. I can sometimes I'm like, all right, shut up, mom, go fuck yourself. You know what I mean? Because that's that negative, you're never going to amount to nothing type of voice. And I was able to identify that after many years. I think, I don't know how many, a lot of them, but it was psychotherapy. It wasn't, I didn't stumble upon it. And it was also the will, the desire to go, all right, something's not right here. What do I do? Well, I got to do something. I want to shift to something that I wanted to bring up, but I kind of forgot.
Noise.
When someone make that decision to end their life, is there a couple questions around that moment? Is there anything you can do once, and maybe there's no info on this, but once they decide, is it how long from they decide to they do it? And in that window, is there an opportunity to talk someone off the ledge, so to speak?
Absolutely, there is. It's not the same for everybody. I think you're in the United States.
Yes.
You live in the gun capital of the world.
Very true.
And one of the downsides of guns is when you decide to use them for suicide, there's no coming back from it. So there's many other ways that people attempt suicide where we can intervene either during or after the attempt. If a gunshot occurs, it's usually quite fatal.
Yeah.
And so the ability to intervene usually is quite limited after the fact. So it's all about what can you do to before the fact. Yeah. There's some alarming, I don't want to get too much into gun control stuff, though I'm a Canadian and I think that there's way too many guns in America. I will say that a lot of guns are purchased by men for the purpose of suicide. And that sucks to know, but states that enact waiting laws 30 days before you can buy the gun or something like that show pretty significant decreases in suicide, and so gun control is definitely going to be a part of the larger evidence-based way to intervene, which is means restriction. So making it so that you have to use your brain to die is really important, because we often, when someone has a suicidal thought, it is fleeting. For some people, it's fatalistic and it's well thought out and there's no changing it. You diagnose with me with Alzheimer's. I love my brain. I promise you, at some point, I would be like, I'd rather not be here. And there'd be no convincing me otherwise. But for a lot of people, they have a type of suicidal ideation that we call the anomic suicidal motivation, which is basically, I got overwhelmed by a stress and I couldn't figure my way out of it. And in those conditions, 99% of the time, it's temporary. And there was a great old documentary called, I think it's called Jumpers. It was about Golden Gate Bridge jumpers. And how they had to install all these things because it became such a famous bridge. And they interviewed people who had survived, and universally, and to a T, there's actually a follow-up study of 100 people who survived. They all report regret while falling. It's a long way down. And while falling, they really were like, man, it was really clear to me that this was a bad idea. So if there's some way to add a pause between action and thought, thought and action, you're probably going to really benefit that person. So anything that reduces means is really good. So in America right now, you can go to any pharmacy, get an over-the-counter version of a pain medication in enough quantity to die. Something as simple as having that in the UK, they're in blister packs and you can only get 20 at a time. It's restrictive, it's encroaching on a freedom. But again, if you're going to impulsively pop out 20 pills to take, it's probably not impulsive, right?
No, that's true.
Whereas taking a bunch of pills is quite quick. So means restriction is a way. And if someone's like really in a moment, it is one of those things where you do kind of have to drop everything and make sure you help them access a professional. Hey, let's get into a hospital. You need to talk to someone. I've been in this situation. I have this thing where all of my patients get my email address. And I've been in this situation where I get an email and I'm like, oh shit, tell me where you are right now. We're going to get you. So, yeah.
Yeah, I can't imagine. With that said, how effective are, and I know I hope you're okay with time. If you're not, just, let me know. How effective are things like suicide lines, suicide chats, suicide websites, and we'll help you, dial 888 or whatever?
They're helpful. I don't want to say they're not helpful, but when you really think about it, they're catering to a group of people who clearly have some ambivalence about wanting to die. Why would you call a line if you wanted to die? You call a line because you don't want to die. You call a line because you're looking for help. You call a line because you're looking for someone to talk to. You think that you're heading down a pathway you don't really want to go. And so in some ways, they're framed as suicide prevention devices. Really, they're suicidality intervention devices. Great for that purpose. But if we really wanted to look at suicide prevention, I would guess there's a whole bunch of people who know the numbers and just for whatever reason decide, I'm not calling. Of course, it can't be effective for those people. So I certainly am not in the camp of they shouldn't be open, but I think we need to be very cautious in saying that the way we prevent suicide is by having a national hotline, because you're almost always catering those types of things to people who will reach out, and you're in a much more advantageous perspective if you're already one of those types of people. And we really actually have to think about the people who don't reach out. Now, for some, not knowing the number, maybe that was a barrier, but for many, it's not what the number is. It's not wanting to call.
Yeah, because I was thinking about how to find some way to integrate that within this group somehow to make it easier, but
I think in a large group you should always have content moderation. You really do want to make sure that if someone really goes it really goes south, we know that there's a contagion effect, and so you really want to shut down those posts quickly, put up numbers for people to call if they're in distress and those types of things. And it's not about censoring or whatever. It's about literally, if you're in a bad space and you read about someone else dying by suicide, it can be a contagion for yourself. And so we do really do want to enact content moderation.
I wonder, in my haze of dealing with this, and I hate to, it's not about me, it really isn't, but when I found out, I was like, okay, I got to tell the group, right?
Yeah.
And then I found out, and Eddie, I'll get to your question, bro. And then I saw his daughter had a GoFundMe, and I posted that. It's also partly because Facebook algorithms fucking suck. So I posted the shit out of that thing because I wanted to say let's get this contributed to, but I also put in the message that he lost his life by suicide, because I also wanted to drive the point home that this happened, these things happen, we can't let this happen. Maybe if I fucked up, I'll be the first one to say it.
Well, I was already seeing the direction your brain was going on that one. I'll say, if you're having a caring, nuanced discussion about a human being, that's okay. What we worry about in contagion is lack of protection in there. So an example is, if all of a sudden the newspaper was like 13 people jumped off the bridge yesterday, and here's some pictures of their gory bodies. That's definitely going to have a contagion effect. But if there's like an article that's talking about the realities of men dying by suicide, there's nuance to that, and so in the same way, you're expressing grief, you're using altruism, you're talking about raising money. There's a pull together effect that's anti-suicidal when people work together for a common cause. So we see after suicides, for example, many people who are touched by the suicide create societies or nonprofits based around that person's death, and no one would ever say, oh, you're creating contagion there. You're adding altruism to this world. So as long as you're adding nuance, as long as you're treating it with respect, you're not being salacious about it. Nobody needs to know method of death. That's really important.
Yeah, I haven't put that up.
That gets a little bit too specific. But I'll tell a funny story about that. Right, I was on the news after Robin Williams' death, and they were interviewing me about mental illness, and it was later revealed that Robin Williams had an advanced form of a rare form of dementia. That was one of the things that was really affecting his mental health. It wasn't his alcohol or bipolar disorder. It was dementia that was really negatively impacting him. But right after they had me on, I was talking to the newscaster, and I said, whatever you do, please don't mention the cause of death. Like, this is just a basic suicide contagion thing. I go home, my wife's watching it. Right after my segment, and live to California, and there's this dude holding up a necktie saying, like, I kid you not, it was like just so and salaciousness is part of suicide. It's an interesting topic, it's a compelling topic. People always want to know how. People always want to know the details. And it is important when you're affecting a large group of people to be effusive about the details, to really include messages of help and how to reach out.
Couple more, and then I'll let you go, my friend. I really appreciate you doing this.
Sure.
How much of a factor is alcohol in suicides?
Well, it's because alcohol, being acutely intoxicated, makes you more impulsive. Almost certainly, if you're down and you're drinking, that's a recipe for increasing your suicidal risk. So if you're drinking as a way to cope with depression, as a way to numb your feelings because things are really going poorly for you, alcohol is going to be a big risk factor. If you're out partying with friends and having a good time, probably less so.
Right.
But certainly alcohol plays into it. And then we know that overall, and this stinks, I wish it wasn't the case, alcohol is a depressant. Like it literally, long-term use of alcohol makes us more depressed. Alcohol is a classic poison. It destabilizes the membranes of our brains. It's not good for our bodies or brains.
Yeah.
It's a socially acceptable way to harm yourself, but it is harmful.
Yeah.
And one of the ways that it poisons our brain is increasing our chance of developing depression. Some people do sort of follow their feelings into the bottle, and that goes against one of my principles. I'm very non-judgmental about substance use, but I'm always, like with kids, I always say substance use is supposed to be recreational. It's not supposed to be therapeutic.
Yeah.
If it was therapeutic, we'd be prescribing it. You'd be coming to the alcohol dispensing center, and I'd be writing a prescription for alcohol. But we know that it doesn't help. It harms you. So if you're using alcohol, if you're using drugs of abuse as ways to cope with distress, you're likely harming yourself more than helping yourself.
A couple questions. Eddie is asking, would you say people prefer a gun over other methods of suicide? And I guess the question is around modality. Like, what are the percentages? Like, what's the leader?
Most suicides are by hanging. And then in the United States, there's a much higher proportion of gun suicides. I would think in the United States, maybe gun suicides are number one. I'll quickly check.
Because I was wondering about that, because Canada doesn't have as many guns, and so I was wondering. I myself was wondering, like, well, what's how do they?
Firearms are number one in America, 53%. So not even close. In the rest of the world, it's not firearms. Firearms is usually number 2 or 3. But of course, there's so many guns in the United States. Males are more likely to own guns than females are, so we see a higher percentage in men than women of dying by firearm.
Man, that's a whole other podcast, I think. He said, Eddie's asking another question. Thanks, Eddie. You said contagious. I think you said contagion. What do you think people learn this behavior as a means to cope with the pain? For example, school shootings, meaning that kids think, oh, look, that other kid was pissed off and went on a shooting rampage. Do you think people learn this behavior?
We often put things like school shootings under the guise of mental illness, but really, there was an FBI report looking at like mental illness rates in school shooters and things like that, and it's not as much of a factor as we'd commonly believe it to be. There's a lot of, we know that shooters are disproportionately male. We know that there's a lot of disaffected young youth. So disaffection is one of the main things there, not fitting in with a group or feeling ostracized from a group, but not necessarily mental illness. Is it a learned behavior? I mean, self-injury is definitely a learned behavior. 1 out of 6 kids in high school age will use self-injury as a way from coping from their distress. So that involves cutting or scraping or scratching or burning or those types of things.
1 in 6.
1 in 6. Wow. And it's socially spread because it works. And there's a portion of people in the population that when they inflict injury on themselves, it makes them feel better. Now, of course, we know that it's short term, that really there's better ways to handle our problems. But again, one of the non-judgmental things I do is I say, well, I get it. You were desperate and this worked for you, so you continued to use it.
Yeah.
Kids have definitely started to teach each other cutting. So we see cutting is the primary way that young people experience self-injury now. And it's way more common than it was, 20 years ago.
I keep adding things. I promise I'll stop. Would you, I'm trying to figure out which one I want to ask first. I'll ask this. What if there's one thing, and I hate to do that, to pin you on to one thing, but if there's one thing that you could do that you could change to prevent suicide, what would that be?
Without question, it has to be if it was up to me, it would be everyone that I encounter leaves me feeling better than when I encountered them. And if you make it, be genuine, be yourself, don't be fake. But if you care about people, make sure you let them know, be explicit about your care. Like, it is not easy to say, hey, just to let you know, I really love you. Like, I would be really, really lost without you, man. Like, really, that's a hard thing to just open up and say. But if you're not explicit about it, when that person has the thought in their head, they don't have that explicit counter message to it. Their brain says, oh, they'd rather you not be around. Personally, I would say be genuine, be authentic, reach out, and try to make people around you's lives better. From a systems point of view, we have to treat suicide seriously. There are so many campaigns about talking, and my goodness, the number of politicians who talk about mental health, just astronomical. Yeah. But suicide is one of the top causes of death under the age of 50, like usually 1, 2, or 3, depending on the nation. Jesus. And yet, compared to cancer, it's like 1/20th of the research money. We get our suicide data a year and a half after the years that it occurs. We need real-time reporting. We need active measures. There's there's 2 famous nations for suicide, Japan and Korea. Japan in 2008 created a national policy for suicide prevention. The suicide rate was about 27 per 100,000, so way higher than America's. Yeah. And over the next 10 years, through a number of things, improving jobs, putting barriers in train stations, adding lots of return to work people for retirees, because they were having old people dying of suicide a lot. They reduced their number from 27 per 100,000 to 16 per 100,000. Wow. Still slightly higher than America, but way closer. Yeah. And so when a nation makes suicide a priority, we can actually reduce a number of deaths. And I never want to make it seem like all suicides are preventable, but a number of them can be intervened on by simple things, like means restriction, making sure that we have safe communities, making people people have access to healthcare. It always blows me away that I'm talking to someone in the richest nation in the world where there is no universal healthcare. Like, it just blows me away.
I've traveled the world, my friend, and I've been in many places, and I've everywhere else has it. You're preaching to the choir.
From the larger point of view, it will require large systemic changes. Like, America definitely needs universal healthcare. There has to be a serious conversation about firearms in the United States, because death by suicide is one of the commonest forms of fatality by firearm in the United States. It's one of the big reasons that people die of guns in the United States. And so there's some real conversations that are well beyond what you or I can do. But I always say, you're in a local environment, there's a big difference to passing someone on the street and saying, hey, how's it going? And if they're looking rough, saying, hey, no, really, you look like you're having a rough time. Is there anything I can do to help? Just be one of those people, be a helper. And the more helpers we have in this world, I think the better it'll be.
Is hope the antidote? That sounds cheesy.
Hope is an antidote for sure, but you never want hope to be saccharine. Like, bad things happen to good people, and some people's don't have easy fixes or easy solutions. So just make sure hope isn't saccharine. If I'm working with someone who has I work in a lot of neuropsychiatric conditions where they have a degenerative course, they're going to die very early. I'm working with young kids who are depressed, who are going to die in their 30s. Or even sooner, I'm not going to be like, oh, things will be okay. It'll be, I want your life to be as good as it can be. And so as long as your hope isn't saccharine and superficial, I think it can be really helpful.
Well, Tyler, Dr. Black, you clearly earned that title, sir. I thank you for doing this. I really, truly appreciate it. The last question I ask everybody is, what words of wisdom would you impart to a man who has just started his divorce process?
This is going to sound trite, but it's not. And that's that, there is a new identity to find when you go through a divorce. And that identity is always going to be better than the identity of being in a relationship where the person didn't love you the way that you wanted them to. And it's always going to be that way. Losing your identity is challenging, but finding who you are is the goal. That's what we're here to do. We are human beings on a tiny ball of rock circling this vast universe. There is no grand scheme to anything except we really need to enjoy our lives, find out who we are, and make a positive impact on our world. And so divorce is really a challenging change in life, but it is one where you have the opportunity to rediscover your identity.
Excellent words,
Yeah.
my friend. Thank you very much,
Yeah,
Tyler. How can people find you? Are there any books or anything?
I don't have anything really to plug. I've generally found on Twitter at Tyler Black 32. I do suicide prevention talks and things like that, and I've published a few articles, but nothing to sell. So feel free to find me on Twitter. And I hope I can't mention it enough. Before I hadn't heard of obviously the podcast prior. I'm not a divorced man.
Lucky you.
I dove into it. I've listened to a few episodes. I've scoped things out. I did my due diligence before coming on, because there are a lot of spaces where it's quite bitter, and the masculinity has turned into a sort of, you know what I mean?
Oh, I do. I see it.
I will say that I really feel like you've done a really good job in fostering a caring and supportive and dare I say loving environment for men who are going through what you've been through. And if there's one really healthy way to process a life, it's through a loss. It's through altruism. It's one of the highest forms of defense mechanisms we have in this universe, and it helps. It really does help. When you do things to help others, it helps yourself. So I just wanted to thank you for doing what you're doing.
Oh, thank you, sir. I really appreciate that. Trying my best, that's for sure. Thank you again for doing this, Tyler. We'll definitely do it again, and we'll definitely stay in touch.
Thanks so much.
Yep.
Right,
take
cheers.
care. Yep. Bye.
Thank you so much for watching and or listening. Thank you to Nick Coyle and Lifer for allowing me to use their song, Born Again, which you're hearing now and at the intro to the podcast. Thank you to Justin Dillahanty and all of my brothers at the Alpha Code. Please visit the website risingphoenixpodcast.com to connect with me and other like-minded men who are looking to thrive and grow after their divorce. And remember to surround yourself with people who add value to your life, who challenge you to be greater than you were yesterday, who sprinkle magic into your existence like you do to theirs. Life is not meant to be done alone. Find your tribe. Take care.